celebrate health success, which fortunately we've been doing quite well this year for the most part, and I know all of us have had little stumbling blocks along the way, but one of the things that I thought today should do would be kind of a celebration of what we've gone through together, many of us, and particularly I am thankful, and I know that other board members of the group are thankful for the fact that so many of you have participated by just showing up and sometimes being very communicative or sometimes being very silent but absorbing information at the same time. And in either case, it's just, it's great to have a group support mechanism, because I think it really drives home some of the lessons that we've all learned over the years of doing what we're doing, which is basically to try to survive and do well given the prostate issues that we might have. So I just thank you for doing that, and particularly I wanted to thank all of you who attended. A couple of months ago we had a mix-up on the schedule with our speaker who came at 12:30. It was certainly not his fault. Dr. John Sylvester is one of the great people in the world, and among other things, he's a great speaker. He's extremely knowledgeable, and he was very, very sorry that he had to go to another appointment for 2 o'clock. He had been told that it was at 12:30, but so we got through that, and he gave me some material, and we used that, and he gave me some material, and we used that material at 2 o'clock. We had a group of about 30 of you, and it was very useful that he gave us the material, but then Ed Weinsberg stepped in as kind of the chair for the day, and stimulated some conversation amongst all of us that I think was really very, very beneficial and useful to all of us. So even without the specialized oncologist and doctor, we can accomplish a lot sometimes on our own, and I think we did that particular day. So again, I thank you all for that, and look forward to future meetings of similar kind of excitement and sharing of knowledge and so on. It has been brought up at today's little board meeting that we hold about an hour before this 2 o'clock meeting, that maybe we should consider a lunch brunch, which we used to do years ago. I'm just going to throw it out at you, and we may put one together for the next meeting in January or for February, I'm not quite sure. But we used to meet at an hour before this meeting, and those of you who wanted to come would come and share lunch. We'd all sit around the table. We would do it on the 4th floor in the cafeteria here, and then you could bring up any subject matter you want. About a year ago, we really canceled doing that because we didn't have enough people to justify that particular session. We may now have, because our group number has built up considerably over the past few months. So we may throw it out there, and I'll make sure you get notified about the fact that we're going to do it. And just feel free to come and join us for lunch and bring any particular questions. What we have done with that session is we've said, okay, at the end of our 2 o'clock meeting, which is usually about 3 or 3:10, several of us will stay and gather and talk to anybody who wants to talk about any issue that's come up in their lives. And if we don't have answers, and most of the time we may not, but we'll have a referral way to get you to places where you can get answers. And if nothing else, we'll bounce ideas back and forth about what our experiences have been. It's particularly useful for new people that have been diagnosed recently or maybe haven't even been diagnosed. I would like to see us get more and more of those people into our group, because nothing is better than having knowledge before your diagnosis. You know, the more you know before that diagnosis occurs, the better off you are. So if you have friends that are concerned about their issues with prostate, tell them to come on in. You know, it's very casual, informal, it's a learning process, it's helpful. So I just encourage you to bring others. And particularly, the factor of having women here is so important to our group. Women or partners, the more the merrier, because everybody has a stake in this disease, whether you've got it, or whether you have a friend that has it, a relative. In many cases, relatives are crucial to your experience, and they oftentimes will have disease issues that you may not even be aware of. So just keep your eyes and ears open and have people come. Let them know that it's a new home. Yeah, Carol.
You might want to mention with the lunch bunch, we usually used to meet at the rear of the cafeteria at one long table.
Yeah. set it up.
Do
so-
that, just look for it.
Right. Well, I'll make sure that the announcement goes out that's pretty clear about where we're gonna be and when. I might even wanna do it downstairs if we could possibly do it, so we don't have to go up and down. We haven't figured all the logistics out at this point. Let me see, a couple of other things. Jan will probably mention, and I'm sure she'll mention, the conference that's being held in March. And I've got a flyer that I'm gonna hand to each one of you as well. It's a free conference that she puts together with her Prostate Cancer International Foundation. And they did one up in Virginia Beach in October that was very successful. They did one a year ago in the Fort Myers area that was quite successful. And they're building upon the process. The most important thing to remember is that it's free. Maybe it's not always the best reason to go to something, but this one will be very, very well put together, I'm sure. So she will probably mention it to you, but I do have a piece that I'm going to give out to each one of you today. It's on March 2nd, Saturday.
The screen says she's talking to Miss Muter.
Well, then we can't hear her.
The mute is for you guys.
Yeah, I think that's more for us.
Yeah.
Yeah. Yeah, I'll make sure to connect with her in just a couple of moments. Let me see, not her, but it says, it does say talking. That may be me. I'm talking. We'll get it connected in a second. I told her 2:15 or 2:10, so. I just wanted to mention a couple of other things. Speakers, we've got speakers set up for the remainder of the year, pretty much. I'll make sure you get schedules. There is a schedule of the dates back there on this little card.
She's online.
That we
She's
have.
online. Now viewing.
And this card tells you all the dates. It's the third Monday of every month. And there are cards back there, so take one of these and go. This does not have the speakers yet because we've changed them around a little bit. But in January, Dr. John Sylvester will be speaking in place of his missing October, and which is not his fault. It's my fault. So, but he's great, and he's an extremely knowledgeable guy. I encourage you to come in here and speak. We need board members. We've got a small board of half a dozen guys that meet every time we meet for the monthly meeting. We meet about an hour beforehand. So if any of you have any interest in helping us spread the word and becoming a part of a board meeting every once a month, love to have you. Just let me know, and we'll include you in. And any contributions of money are greatly received. We don't need a lot, we just need a little bit to print some of the articles. That's probably the primary expense. We spend a little bit of money on food. We went over the board today a little bit, but normally it's a very minimal expense for food, and the printing is a big cost. So.
Everybody sign up.
Yeah, if you would, make sure you sign in on the sheet, even if you don't put
putting us names.
yeah, if you don't put a, if you have an email, if we have you on our email list, you don't need to repeat it. Or if you have just a straight mail address and you've been getting our mail, then you don't need to repeat it either. But if we don't have your address, please do put it down. Well, maybe we can connect with Mackenzie here. If Mackenzie,
She stepped out, so she said all you have to do is hit the red button up
the
there.
red button, is that
And I
gonna
think
do
you
it?
should be good to go. I think she'll be able to hear you speak. There you go.
You are unmuted. I wonder if Jan is.
Hello.
Hi.
Here's Jan. Hi, Jan.
Hi, how are you?
Happy holidays.
Good. Happy holidays. It's coming across
Happy holidays.
a number of people. Well, I've introduced you a little bit, but let me just say a couple more words about Jan Mannerite. I was diagnosed 7 years ago with prostate cancer. I knew nothing about I can't say that. I had done a lot of research beforehand, but nonetheless, after that day I was diagnosed, suddenly it was a real world. It was no more just reading in books and understanding. Now I had the darn disease. What do I do next? And a good friend of mine recommended this woman what was the part you're on the island there?
I was at Sanibel.
Sanibel. And my friend was from Sanibel, coincidentally, but he knew of Jan, and he said, "You've got to call her up." I hesitated for a while. I thought, well, you know what? Does that really make sense? Well, I found out it did make a great deal of sense. Within a week, I was on the phone to her, and just opened up number of doors, including options that I had for treatment. And just how to go about diagnosing it completely, making sure you understood the disease. Because more often than not, I think, once you're diagnosed, you really don't understand what you're going through unless you've done tons and tons of research. Excuse me, water, I guess, but any event, Jan is here to answer any questions, and I have mentioned the conference in March, but you might want to mention that right off the bat too.
Sure.
So
Yeah.
I'll leave it in your hands, particularly since I can't speak.
Okay, then if I can't speak, you can cover me.
Yeah.
Yeah. So, what I do is, with my husband's journey, my husband, passed away in 2013, but he was diagnosed in the year 2000. And some of you know this story, but, because I've spoken at your group before, I've been around for a long time. Yeah. I've been doing education and advocacy for 17 years now. So, when my husband was diagnosed, his PSA was over 7,000, okay? Over 7,000, and his Gleason was 9, and he was very stubborn, he was in very bad shape, and I was 15 years younger than him, and one of the first things I learned was that we didn't really understand enough about what he had. We didn't really need to know prostate cancer in general. We needed to know what he had. One of the first things that I researched actually was bone integrity because he had so much cancer in his bones. So I learned very quickly that developing better questions got me better answers. So my job was to develop better questions, not just ask the first thing off the top of my head, not come into the doctor's office and try to talk about something I think I saw on television. I needed to develop questions, and specifically from literally my husband's medical records. I learned to pull them up, research a few big words, and it turns out that I could understand what they were saying. They were just inventing new words that we didn't need. That's what science does. So, he lived for 13 years after that initial diagnosis, and I chose probably 80% of his treatments, believe it or not, because we didn't have a lot of FDA-approved treatments for advanced metastatic prostate cancer at that time. We've got several FDA-approved now, which started in 2010 with Provenge. But we're always, without proof, looking for evidence. So always trying something new, looking for a small study instead of a large one that was perfect. We didn't need perfection. So that's where I come from. And the place that helped me was PCRI in Los Angeles. They hired me. I worked there for 13 years. I led the helpline. I did public speaking. I did writing. And so then I moved to another organization, and now I'm with Prostate Cancer International. So I would definitely like to get to your questions, but real briefly, you guys can see my screen, right? My computer screen?
Blocked.
Yeah, so I have the conference website up now. It says Prostate Cancer Today.
Yes, okay.
Yeah, so here's some of the speakers we have. I'll talk to you about a couple of highlights. Well, I think the first thing I want to tell you is that I developed the entire agenda for the October conference with Mike Scott. He's our president, with his input and edits and insight. But I decided that people need smaller sessions, much more targeted to what they have and what they need. Nobody needs a big room full of 200 prostate cancer patients talking about something that applies to 25% of them. So I created 16 different smaller sessions. We call them breakout sessions. And you might think I was crazy. I thought maybe I was too, but we did it. And it was a great conference. The best comment and feedback we got was from Peter Moon, who's a US2 support group leader in Virginia. And he emailed me and said, let me see if I can pull this up here. Great conference. the best I've been to in the last 24 years. And he's a PhD and support group leader in Virginia, so that was my biggest thumbs up. So we got a lot of really good feedback, because I think I really try to think like a pig. So we're bringing one to Fort Myers March 2nd, so it's about 2.5 months away. So I just want you guys to know about it. It's free. I never charge cancer patients, because I would never turn away a cancer patient because of money. Okay? That was my idea. PCRI charges people, that's fine. It's cancer. Some people struggle financially. We do ask for a $25 donation if you have it. If you don't, no big deal. Nobody knows whether you paid or not. We also give you free lunch because we have sponsorships, and the sponsorships create tables in the exhibit hall. So that'll give you free resources to visit in addition to the conference itself. So this is what we're doing. David had flyers, so I want to move on, but I just wanted to mention that quickly. These are some of the topics, and we do have speakers that are advocates like myself, nurses, hopefully a specialty pharmacist. So it's not all doctors. We need the doctors, but we need other people in the mix too. So we bring in a variety of types of speakers, especially nurses. So,
Jan, excuse me.
Yes.
The handout that I just gave out has the conference page number 3. The third page in shows you.
It has, I'm sorry, what?
It shows the speakers and everything. The handout that I just gave them is
Right.
the flyer for the conference.
Yeah, so it'll look like this website. I just wanted to walk through it real quickly.
Yep.
The other thing we're doing that I've never seen anybody else do, we did this in October in Virginia, is since radiation is so ridiculously complicated and almost impossible for people to understand, instead of having someone stand up and talk about radiation with PowerPoints, we created a panel discussion. So it was almost more like a politician's debate. And we put 4 physicians at the table, gave them all the same questions, and allowed them to just verbally give answers for patients. We're doing the same thing in March in Fort Myers. So we have 1 radiation oncologist for 4 different types of radiation. Number 1, proton. Number 2, CyberKnife. Number 3, IMRT. And then number 4, SEEDS, which is brachytherapy. I actually asked John Sylvester from Sarasota to speak, but he's out of town. So that's another thing we're doing. Just so you know, I think it's great because I've never seen anybody do it, and radiation is confusing. So anyway, so that's where I'm at. I have these questions from David. I could start to walk through them, or we could take Q&A from the audience. David, what do you think?
Anybody have any particular? Yes, go ahead, Ed.
I think it'd be advantageous if you reduce the bottom half of the screen so we can see more of you. You're sort of stuck at the top visually for us. So in the dialogue, can you bring the screen display down and yourself up?
I want you to see my screen though, because I'm going to show you what I'm talking about. Is that okay?
Yeah.
Can you minimize the go-to, at least go-to meeting, minimize that part of the screen?
Well, maybe I can do that.
Is that better?
Let me see if I can do that, Jan.
You might.
Okay.
Don't exit.
That's right, don't exit it.
Oh, excellent.
Minimize, don't X.
Yeah, minus.
No.
Minus. Minus.
Doesn't want me to minus.
Right, it's next to the X.
Right. Yeah, you're right, it is there, yeah. Just get this thing up. Uh-oh, not so good. I did more than minimize it.
You have your AV person still there, your audio visual person?
I got it back just the way it was. So best to leave it alone next time.
Okay. It's important that you hear me and see the screen. So can you guys see the screen?
Yeah, go ahead.
Okay. So, yeah, so see, these are the questions that David sent me. You want me to just walk through them and I'll tell you what I know and what I don't know?
Okay,
Yeah.
yeah, that sounds good.
Okay. Right, so the first one is about incontinence and, ED, which is sexual dysfunction, which is most common with surgery, less common with radiation in general. It's not my area of real expertise, Dave, I'm sorry, but I tell you what I would do. We have a social network online. Is Dave Howell there?
Dave Howell, yes, yeah.
Okay, so we have a social network online. I'm going to show it to you. And what I would do is go here and sign up. Mike is much better at these questions than me. So, I will tell you this, if you're counting on a surgical, intervention of some kind, I would really work to make sure that my surgeon was an expert. Because, are you guys familiar with, the fact that all urologists are trained and board certified in surgery?
No.
They're not trained and board certified in internal medicine. They are surgeons, simply put. So all urologists are surgeons, and there's a lot of different types of surgery. Some are better at some types of surgery than others. So, if you're considering some kind of surgical intervention for either incontinence or ED after surgery, one of the things I would do if I was in a support group is just ask the guys in my support group about the local surgeons and what they've had done by them. And this isn't about validating the person, saying he's a really nice guy, because that doesn't matter when you're on the operating table. You're out, he's awake. You know, so it really matters. You can talk to someone who's had surgery by him, and you can understand if their situation before they went into surgery was similar to yours. You can also call, there's two companies that sort of make the devices that go into prostate surgery for incontinence and ED. Let me write this down. You can call these companies and ask them if they have a recommendation. It's probably not quite as objective as some, but it's not bad. So these are the two companies, Boston Scientific and Coloplast, that make the apparatus used in these types of surgeries. So if you're looking for an expert surgeon for incontinence or sexual dysfunction, I would consider calling them and asking, or looking on their website for recommendation.
Jan, can I enter something too?
Please do.
A couple of months ago, maybe it was just last month, we had Dr. Joshua Green speak to us. And it was really a very good talk, I thought, very frank, very open, very considerate of ED and incontinence and other issues that can come up. So he's a local resource here too, and I do have his video, which I'll make sure I get a link out to you about that. It's probably 45 minutes long, and you just might want to watch that and get some field feedback from him.
He's a local surgeon, right, David?
Yes, yes.
Yeah. Okay. Has anyone in the audience had surgery by you? And if so, are you comfortable, saying yes or commenting on it? If not, that's okay.
Yeah, I don't think anybody has.
Okay. Yeah. So those are my tips on that, and I'm not the best. Those aren't my areas of the best expertise. So sorry about that. But I hope that helps a little bit. So I'm going to move on to the next question, which is it still true, as it was 10 years ago, that 3/4 of current annual diagnoses of prostate cancer are for men with early stage disease? So 3/4, I think they're asking if 3/4 of men diagnosed are still early stage. Good question. I don't spend a lot of time in statistics because they're pretty easy to Google and look up. American Cancer Society talks about statistics a lot. I know there was a shift when the U.S. Preventive Task Force recommended against PSA screening and there was a shift in more advanced diagnoses happening as opposed to earlier stage. I know they changed the recommendation, so it's more favorable now for screening for prostate cancer. So it may be shifting back, I'm not really sure. I really tend to focus on the individual and their situation. So I hope that helps, but I think that's something. The other problem is early stage. Early stage is kind of, I don't know, it's hard. When it comes to staging in prostate cancer, they use a really unique way to do it, and sometimes that needs a definition, especially for newly diagnosed men who want to know what they have. Early stage is kind of a really loose definition, so sometimes if you're newly diagnosed, it's better to define that much more clearly. So, does anyone have questions on that? Follow-up questions to that question?
You know, again, I can just make a comment about early stage. I think when I was first diagnosed, and it probably is true of many of you, that I was given a Gleason score. I was given a number of cores that had been exposed, and the percentage of each core that had been was cancerous. So that's all I really had to go on. And as to stage 1, 2, 3, 4, I didn't know what stage I was really at. The doctor did say you're at a low level, or low risk. And that's about all I knew at the beginning.
Yeah, they don't always explain it real clearly. Partially, they don't have time, and some doctors honestly don't care to explain it to you that well. They're just going to take charge of your care. So, is anyone in the audience newly diagnosed?
Yes, we have one gentleman, yeah.
Okay, is this something that's important to you? Because I can elaborate a little bit for you.
Sure.
Okay, so to know what so in newly diagnosed, the staging is simply what they found on digital rectal exam, okay? These are the stages for newly diagnosed. It's that simple. About 3/4 of men are diagnosed with T1C, which means they could not feel anything on the DRE. That's your clinical stage, okay? The most men have a T1C. If the urologist did feel something that he called either hard or a nodule, that's called a palpable lesion. And if it's small enough, you're a T2A. If it's a little bit bigger, you're a T2B, and so forth. So my first guess is you're probably a T1C, as 3/4 of men are, but if not, it'd be good to know what your stage is.
They
But
couldn't,
this
feel,
is,
they couldn't feel anything on the rectal exam.
okay, then it's important and helpful for you to know that your clinical stage is T1C. See it on the screen?
Yeah.
That's what you have. Okay, that's your clinical stage. So, then they'll take that and factor in other things like your Gleason score, and a few other things, and they'll give you a risk category. So do you know what your Gleason score was?
It was an 8 on one biopsy core.
One core, an 8 on one core.
Okay, so I assume they did 12 cores, correct?
That's good enough, yes. There were 18.
Mine was 8 cores, that's all they did.
Yeah. Was this your first biopsy?
Yes,
Did they do a prostate MRI before the biopsy? I'm guessing no.
yes, they did.
They did.
Oh, they did? Okay, that's good. Okay, on the prostate MRI, were there any spots
Yes.
found that were IRAD 3, 4, 5?
Yes, there was one lesion, solitary lesion in the apex.
One solitary lesion in the apex?
Correct.
Got it. Okay. So the apex is the bottom of the prostate. The prostate, if you think about the apex of a triangle, prostate is sort of like the upside down triangle, so the apex is at the bottom. The thing that's of concern is the Gleason 8. One core is favorable. I might consider asking to have that pathology sent to Johns Hopkins for expert read, because that Gleason 8 all by itself puts you into a high-risk category as opposed to low risk, very low risk, or favorable or unfavorable intermediate. It puts you into high risk just because of the Gleason score. How long ago were you diagnosed?
A month ago.
Okay. So, insurance usually pays for an expert second opinion as your doctor on the Gleason score. Has your doctor talked about that at all?
Yeah.
I had
Yeah.
I had John Epstein do a review of my Gleason, and he upstaged it one time. Yeah, I had Gleason 6 for 7 years, and my cancer wasn't behaving like a Gleason 6. And so Mark Schultz said, we can have John Epstein review your slides, and sure enough, they had underscored it. So it makes sense to have an expert look at it.
Yeah. A second opinion.
Especially when the Gleason score means that much. In your case, it sounds like there's a lot of favorable things, and there's this one unfavorable thing, which is the Gleason 8, which is the one thing that's putting you into high risk category. So if that was a 7, you'd be in considerably different category. So now, do you know what Gleason measures? Has anybody explained that to you?
Yes.
Okay, so
Some say no, so
Gleason.
go ahead and explain, I think.
Oh, sorry. All right. It tells you how aggressive or non-aggressive your cancer is. And believe it or not, 6 is the best. There is no 5, 4, 3, or 2. So 6 is the best, and there's 7, then there's 8. So 8 will be probably a 4 plus 4 equals 8. And that 4 is, in simple terms, aggressive disease. It's not as bad as a 5. You know, you could have 5 plus 4 and 4 plus 5, or 5 plus 5. So it's not as bad as that, but it's enough to put you into high risk category. So I think that's the first thing I would consider. Do you know what percentage of the core was cancerous?
60%.
60? Is it 60 or 16?
60.
6-0.
Okay. Yeah. That's for me. That's the first thing I would want. And what you're doing by sending it to Hopkins is not just getting a second opinion. You're getting an expert opinion on the Gleason score, because the Gleason score is being such an important marker because it measures aggressiveness or non-aggressiveness. It's done under the microscope. It's a visual determination. There's no staining involved. There's no computer calculating. There's no specific type of tool. It's a visual decision by the pathologist himself. And you don't know how many different cancers he did that day, or if he did infectious disease, or how many other things he did. But Hopkins is the noted expert. There's others, but Hopkins is the top, probably, and has been for years. And the other thing about Hopkins, since every urologist knows exactly who Johns Hopkins is, it just makes it easier for the patient to ask. Your urologist has probably already done that for another patient. So I personally know how hard it can be just to work the medical system. It can be exhausting. So using Hopkins, and because they're an expert, just makes it reasonable and workable and easy. So I would call my urologist and ask him specifically for that. Now you can call Johns Hopkins and ask them, make sure your insurance pays. My understanding is that they usually do.
Yes, they do. Yeah.
But it's always good to ask. Let me see if I can pull up the phone number here. Hold on.
The other thing, Jan, is can't he independently go to the lab and get that result without going to his urologist?
Yeah, but I believe the urologist has to order it for insurance to cover that thing. Double check me on that, but I think that's the way it is. So here's the phone number for you. You can call them and ask them if you have your insurance card in your hand. Ask them if your insurance pays, and ask them the best way to do it.
the
So-
insurance is not there, they charge $250 for the review. So it's not, exceedingly exorbitant. I did not go through
No.
first.
I think that's a great next step to consider, I really do. Now, yeah, and then you can revisit the issue. My second question for you would be, do you know the size of your prostate? The MRI will usually state it, although it's different on ultrasound. Is it 30 grams, 40 grams, 50 grams, 60 grams, 70? Any idea?
It was 30.
30 grand? Okay. Okay, so that means, in my humble opinion, that 12 cores with an MRI first should be a pretty good sampling. I've had callers, my worst one was a caller with a 200 gram prostate. I think my first question to him was, where the heck is your urologist at? Because that's ridiculous, for lack of a better term. But, everybody's different, so, but to try to do a biopsy on a larger prostate, it always leaves more question. Was it the sampling? If they didn't use MRI before, they have no target. So it seems to me, they've set you up for pretty good sampling on the prostate, so I hope that gives you a little bit of confidence. So, what was your PSA before the biopsy, PSA?
It was 4.4.
Wow, okay. Yeah, so your PSA is also favorable. So the only unfavorable thing you have is that Gleason score, which is knocking you out of the other risk categories into high risk. So that would be my best spot. Okay? Any other questions? I'm gonna move on to the next question if you guys want.
Well, where does he go from here? I mean, does he get does he go with different
Expert
procedures?
opinion on the Gleason. Expert opinion on the Gleason. You need to know what your Gleason is to make a decision, and he has it, but I think it'd be great to get a second opinion expert opinion, excuse me, since everything else is pretty favorable.
But I
What
mean,
if the Gleason's wrong?
would he go with radiation seeds? Would he go with surgery? I mean, is that up to him, or how does he explore things like that?
Well, it's up to him, yeah. And, there's pros and cons for all of them, right?
Right.
So, for example, with a small prostate, you can really consider radiation without having to deal with a lot of side effects. If your prostate is greatly enlarged, you're at much higher risk for side effects. So with his prostate being 30 grams, radiation is definitely something you can look at. If he was to look at radiation, I might suggest considering CyberKnife Centers of Tampa and Deborah Freeman, who's speaking at our conference. Maybe I'm a little bit biased, but I know that with CyberKnife, you have fewer treatments to go through. And the literature on CyberKnife, and it's also called hypofractionated radiation, just continues to look favorable. So Tampa's not that far away from you. CyberKnife Treatments Centers of Tampa and Dr. Deborah Freeman, I think, would be a great thing to at least go get a consultation. You could consider seeds, and if that was the case, I might think about John Sullivan, Sarasota. Sullivan, right? Did I get that?
Sylvester, yeah.
Thank you, Sylvester. Sorry about that. John Sylvester. He's a well-respected brachytherapist or seed implant physician, and I would probably argue that the data for seeds and CyberKnife might have an edge on the other modalities, the other types of radiation. So those are two good things, to consider. You can certainly consider surgery, but you're going to be at higher risk probably for both definitely incontinence, and sexual dysfunction. That's likely, okay? If you were to choose surgery, I would really argue for seeking out an artist Every urologist is a surgeon. That doesn't mean they're an excellent one. Part of the issue is that the anatomy is so, it's kind of ridiculous. I mean, the prostate wraps around the urethra, it's next to the bladder, it sits on top of these nerve bundles, right next to the rectum, behind, the anatomy is so hard for a surgeon. And I've heard, Dr. John Mulhall from Memorial Sloan Kettering describe those nerve bundles in his view. He called them one day saran wrap. That's how delicate they are. If you touch those nerve bundles or disturb them, you're probably going to leave a man with some amount of sexual dysfunction and or incontinence. So it ties into incontinence a little bit and into sexual dysfunction a lot. So surgery is challenging. It's for the right patient, it's definitely the right thing, but you gotta think risk and benefit, pros and cons, and then weigh them out.
Jan,
So-
can I just wanted to ask one question. Has your urologist recommended a course of action yet?
It was sent, the slides were sent to an oncologist to look at,
Uh-huh.
and they were confirmed to be Gleason 8. So he suggested that to have the robotic Da Vinci surgery.
With who? That's what's important, with who?
Here at Sarasota Memorial.
She is, which doctor?
Dr. Perry. Dr. Perry.
She does not carry.
So has anybody in the audience had surgery by this surgeon?
Well,
Dr. Carey,
speak up.
think
I am Carrie, not Harry.
It was Dr. Carey?
Dr. Perry.
Perry.
Harry.
Perry.
I'm gonna give you a name of someone who has had surgery by him, and it's Steve Gordon. He runs a support group over at Doctors Hospital, and David Morse knows him really well. You can talk to Steve Gordon about his experience with Dr. Robert Carey in surgery. Okay, that's one.
Talking about a Dr. Perry, who I think is somebody different.
Perry
Oh,
with the P?
got it.
Yeah.
Perry.
Perry?
Okay, so the surgeon is kind of everything. Everything. I'm gonna give you a name in Orlando.
Is it general? He does everything?
Yeah, I'm gonna type it in here, okay? Dr. Vipul Patel.
That's right.
I give you an artist, all right, to consider. When I say consider, that means I'm just giving you the name, look it up, you can consider an appointment with him just to talk to him. You can, has anybody in the audience had robotic surgery by anyone?
Got a few hands up.
Put your hands up, tell us, who was it?
So after the meeting, I would be talking to those men, asking them to give you honest feedback about their experience, and then ask them about their prostate cancer before the surgery, so you can tell if their situation was similar to you. For example, having one core positive is favorable, but if it's in the apex is sort of an undefined area that's, they call it all peripheral zone. It's a lot of big words. We're just saying it's difficult to get a clean margin there sometimes, and it's difficult to tell where the prostate ends and prostate starts. And it also can be easier for the cancer to escape in the apex. So for me, those would be some good questions that I'd be asking.
Yeah, I've got another question, Jan, from right here, from John.
Yeah, I'd like to ask the gentleman, did the doctor explain to you why he recommended surgery as opposed to radiation? Did he give you the rationale of it?
Yes, he did.
Can you share it? Can you share it with us?
Due to my age, and that the PSA marker was going to be lost if I did, it should be 0, your PSA, after you do surgery. And that marker could be followed as I go on. And if they remove the prostate, then the cure would have been a higher rate.
Whether the cure would be a higher rate, I don't know. Different doctors argue 6 different sides of that issue all day long, and they have for all the 17 years I've been doing this. So I'm gonna suggest that might be subjective. Whether it's the question is a higher cure rate for somebody like you? What is your age, if you don't mind?
66, 66.
Okay, just being over age 65 begins to increase your risk of sexual dysfunction from surgery. Did he tell you that?
Yes.
Okay. So, yeah, I don't know. I think you have some time to think about it, but I think you, because you're canceling the apex and because you're 66, you're a considerable risk for sexual dysfunction. He may quote you a general statistic, but you want to know about you personally. You personally. That's all you want to know about. I would factor in age. I would factor in the fact that it's in the apex. If you had 60% of that core involved, there may be a significant tumor burden that they found there. That suggests that they're not going to be able to spare one of the nerve bundles, one of the 2 nerve bundles. That would be, and I would look and see what the MRI is saying about that. So just those things alone make me wonder and sort of lean towards considering CyberKnife or Cs and wondering if there would be more benefit and less risk for you. But those are just some thoughts for you to think about. But it's hard for a surgeon to be objective. I'm really comfortable saying that it's been 17 years. I'm really comfortable saying that. So let your medical records speak to you. Look at the MRI. Does it talk about anything about extracapsular anything? Extracapsular extension, extracapsular projection. I mean, they use all different kinds of words. Extracapsular, which means extra outside of capsule is prostate, outside of the prostate. So sometimes they'll say extra prostatic extension cannot be excluded, which means they don't know, but it's possible. So if that's the case in the apex, I would ask about how gentle they can be in that area with a scalpel when they're right next to your nerve bundles. Because if there's a chance that it might be outside the prostate. Whereas the rate can reach further, and it does usually a lot less damage, usually. So,
anything else on that?
no, I hope that gives you some questions to ask and some direction based on you personally, not on prostate cancer, but on your prostate cancer, which is all you care about. So, I hope that helps. And you're welcome again to join the social network. Let me put the link up for the social network if you guys don't belong.
I'll make sure to send this out to you all too, so you don't have to scribble it and write it down.
And our president, Mike Scott, is on the social network a lot, and he has a real deep knowledge of the data overall and the history, the context. He's super smart. Been a medical writer for like 30 years, so he's really good at it. So if you'd like to join the social network, that might be helpful.
Yeah, Dave, can you just email everybody the social network? That'd probably be good, just email that.
Yeah, he'll email.
Okay. Okay, do you want me to go on to the next question?
Yes.
I think so, yes.
Okay. What proportion of those early stage patients decide, and these are kind of generalized questions, so I don't know exactly how many. I think we answered some of it by talking about risk versus benefit for the previous guy. It's okay if I move on?
Yeah, I've got a comment I could make on the early stage prostate cancer, Gleason 2 to 6.
Sure.
It's,
Please, what? I'm sorry.
I just want to make a comment on that question. The question is, what proportion of men who have early stage Gleason 6 end up 5 years later with Gleason 8 or 9? I think that's the question.
That is
And-
the question.
And part of the answer to the question is the first diagnosis and how accurate that diagnosis is. And sometimes you have to be very careful. For example,
Yeah.
in my case, I had 8 cores taken samples from, which isn't a lot of cores, and I had a Gleason 6. And I lived with that for 4 years, and I based my treatment on that score. And then 4.5 years later, I learned I had Gleason 8 and 3 cores. Quite a distinct difference. And it may very well have been that my first diagnosis was not 100% accurate. And
Right.
that's why these MRI, particularly the parametric MRI done before a targeted biopsy is so important. And most of the doctors now are doing that. And then you know when you get the diagnosis that it matches up with something that shows the entire prostate. So you just got to be careful.
Yeah, and, the prostate MRI, the PIRATs that we have, wasn't around until 2012, I think, is when it came out, so, so you guys in Sarasota do have a good prostate MRI facility, and it's Partners Imaging in Sarasota. So I'm just gonna, that facility, they're well respected, and there's a doctor, I forget his name now, who's very good there.
Goldberg, I think.
Goldberg.
Dr. Goldberg.
Yes, Goldberg, yes. So, yeah, you're right though, David. It's not so much an issue of just Gleason 6 turning to 7 or 8, because I think the data's pretty confident and pretty strong when it doesn't. Gleason 6 stays Gleason 6. But it's more of a question is when they put all those needles into, let's call it an orange, did they miss anything? And so that's where the prostate MRI really helps, because before that, the imaging we had was pretty crappy, to be honest. They were just using grayscale ultrasound, which is what you use to, look at a baby when a woman is pregnant. And I mean, you can't see, it's not designed to see cancer cells at all. So its ability to even find the cancer is less than 50%, less than. I'm being really generous. It's probably more like 20 or 30%. But the MRI is more like 75 to 80 or 85% accuracy. So got that great tool available for you. And sometimes the doctors do not order MRI before the first biopsy because insurance may or may not pay. But if you either had a biopsy already or you've been diagnosed with prostate cancer, my understanding is your insurance does pay. And even then, sometimes you can fight for it, or if I understand right, Partners Imaging does a prostate MRI for $600. It's not like $3,000, so some people can afford that. So the issue with insurance covering just means that you don't have to pay. The other issue is if they do the prostate MRI before the biopsy and you pay the $600 and they find cancer, they may come back and reimburse you because they found the cancer. So a lot of this is just working the darn system on your behalf and in your favor. So.
Partners Imaging is right down the street here, by the way. It's very close to me.
Okay. Yeah. So, okay, moving on. I don't remember where I was. Did 1, did 2. Do you guys want to talk about HIFU a little bit? Because it's sort of a unknown, there's misinformation about it.
Yes.
Okay, you have, okay, so HIFU is just a local treatment to the prostate itself. HIFU, the first question you need to ask about HIFU is, will insurance cover it for me? The second question you should ask is, well, there's 2 kinds of HIFU, let's say. One is where they do HIFU to the entire prostate. And just like radiation, you don't want the prostate to be too large because you won't damage the rectum or the bladder, so the surrounding areas. It's simple anatomy. But the second question is, when you research HIFU online, and HIFU is high intensity focused ultrasounds, basically heating up the prostate. When you research it online, you'll either find whole prostate HIFU or focal HIFU, which means they treat just one part of the prostate. And Dr. Steve Scianti over by Doctors Hospital does that. But for focal HIFU, you need to ask about money. sometimes insurance doesn't cover. And I know some focal patients pay for HIFU, focal laser, focal cryo for like $20,000. So that's the first question. Okay. So Medicare does cover some of it, but I'm pretty sure they do not cover all of it. So there will be an expense. So in my mind, that means that it has to be better than the things that that insurance does pay for, like radiation, which we have more data for. So it kind of takes you back to radiation for the most part, although there's always exceptions. So we have more data on radiation, and insurance does cover it. Kind of makes the case for some type of radiation if you're choosing a targeted new prostate. So.
What about cryotherapy, Jan?
Cryo is freezing, which is obviously the polar opposite of heating it up. And insurance does pay, is my understanding, and has paid for quite a while. Steve Scianti is another name I would recommend. But again, you don't want the prostate to be too large. It's the same issue. If it's too large, you're going to hit the surrounding organs and surrounding tissue and create side effects. The prostate's reasonably small, and I would say 50 grams or smaller, maybe 60 grams or smaller. You're going to find different opinions on that. Then it's much more of a reasonable idea. But I mention that often because I find doctors sometimes don't mention it. So, so I would refer to Scianti for both HIFU and cryo over by Doctors Hospital. Steve Scianti. So does that help? Okay. What did I earlier say? By the way, there is no Gleason 2, just so you know. So I'm going to go ahead and cross that off for you. This is part of the misinformation I deal with all the time. So Gleasons go from 6 to 10. All right, there is no 2. There's no 3, there's no 4, there's no 5. And by that I mean the sum. That means the 2 numbers added together to come up with a 6, 7, 8, 9, or 10. Okay? Likely to develop beds. I don't know, again, I don't do a lot of statistics. I try to help people with their individual situation. I did write an article called Understanding Survival Statistics. It's really hard to say who's going to survive how long. And honestly, the studies that the doctors rely on to try to tell you how long you're going to live, the first thing you have to do is look at the year the study was done. I have never seen a study on prostate cancer survival that wasn't terribly outdated. And the reason is, if it takes them 5 to 10 years to gather the data, by the time they publish it, it's already outdated, right? I mean, things have changed. And in addition to that, things are going to change next year, and they're going to change the year after that. So I think it's one of the worst statistics that we have. And I'd be happy to email. I wrote an article on understanding survival statistics because I got so frustrated listening to my callers tell me that their doctor said that they only had 2 to 4 years to live. And I would tell, my husband lived 13. And they'd say, really? I'd say, yes. So, what study did you get that from? Oh, it was published in 1999. It's outdated. We can't, there's just some things that we cannot measure accurately, even though I know you want the number. But I'm always going to tell you that your personal involvement in reading your medical records, yes, reading them, Googling the big words, coming up with better questions, getting better answers, that is the single most important factor in your survival. Nobody can measure that. There's not going to be a study to tell you what that is, but I lived it, so I have no problem saying it. So stay involved, read the medical records. Don't say I have a copy in a folder at home. Pull it out. Pull it out, look at it, and Google a few big words, circle them, ask your doctor what they mean. You'd be surprised at how much, the light bulbs come on for you. And you begin to learn something about yourself personally that means something to you. It means more to you than anyone else. So that's my little spiel on survival.
Well
I
taken.
hope that was
Well taken. I tell you,
Yes, and I live-
lived by it. I mean, I was lucky enough to speak to her 8 years ago, and I lived by what you just talked about, and that was to keep a complete record, which is way too thick at this point. But, what a remarkable relief it is to be able to go back and look at studies that, or tests that were done 6 years ago, and what the results were. And being able to talk to your doctor, push your doctor, just push him. You know, they'll all respect you for it. They may not want to spend the time, but I think you, if that's the case, then you need to move on to another doctor, and that's, just look around.
And to know about your prostate cancer, it's one thing to go on Google and Google prostate cancer, but I mean, there's so many different kinds. Really, all you want to know about is yours. Right? You want to know what you have personally, because it's different than the guy sitting next to you in the room today. So what do you have? You know, pull up those medical records. One example is, here's a really common one on a CT scan. They'll look at your lymph nodes, okay? What they're doing, they don't explain this. They're just looking to see if you might have cancer in your lymph nodes, okay? But since a CT scan is such a poor imaging, all they can see is anatomy, shape, sizes, things that are too big. They don't tell you that. They simply measure the lymph nodes. When they measure them, if they're too big, they're cancerous. That's all. They don't see cancer cells. And in addition, they'll use this big word. Here it is. And they won't tell you what it means, but it's lymphadenopathy. That just means a large lymph node. Well, you'll see that, a large lymph node. You'll see that word on your CAT scan. You go, oh my God, I don't know what that means. Google it. It just means a large lymph node, and it's yours. You know, and it means you probably have cancer in that lymph node. There's times where you can consider, some men will consider having a lymph node laparoscopically removed, or have radiation to a single lymph node. If there's, for example, a good example is if you have just 1 or 2 large lymph nodes. Again, everybody's different, right? Some men have multiple lymph nodes with just a little bit of cancer in them. Some men have just a few lymph nodes with a large amount of cancer. Few lymph nodes with a large amount of cancer is something where you can ask about, can I just zap that lymph node with radiation, or can you laparoscopically remove it? Now you're learning about your personal prostate cancer, which is all you really wanted to know. So this is the journey. This is the journey, reading your medical records. So these are kind of general questions. Again, I hope you guys don't mind. I sort of skim over them, and it's 3 o'clock anyway.
Yep. Are there any other particular
Yeah.
questions that anybody has that you want to bounce off of the expert? Not me, or,
I do.
yes.
Okay, I was diagnosed in 15, and started my treatment on September 1st of 15. And on the 3rd day of treatment, they gave me a Trelstar shot.
Got it?
Without explaining that was to knock my testosterone to 0, shrink my
Right.
penis,
Right.
and do a lot of nasty things that appear not to be able to be changed. When I talked to
No, it might change. We'll come back to that. Okay.
When I talked to my doctor, I said, well, can you give me something to help my testosterone get back? Because as I look back on the records, and I guess debate is out there about this, but for the longest time, my testosterone was only about 250 anyway. And I'd read that low testosterone is a high precursor for future prostate cancer. Okay? I'm asking him, can he supplement my testosterone? And he get that age-old saying, pouring gasoline on the fire, which really pisses me off. I need a better answer.
You were doing radiation?
Yeah.
Yeah, I did proton.
Oh,
Oh, you did? Okay, so you did Trelstar plus proton.
Right.
Okay. So how many Trelstar shots have you had?
1. They gave me the option.
Really?
They gave me an option of a single, a 3-month, or the granddaddy. And I didn't want to keep going back for it. And I unfortunately took the granddaddy, and it left me with a mark that is still visible on my rump where they shot me. I had a bruise that looked like somebody hit me with a baseball bat. I know they did something wrong, and they denied it.
So here's a thought I want you guys to catch this. A lot of medicine is, believe it or not, simple common sense and correlation. So when you get a new treatment of any kind, like a shot, an injection, and your body's never been introduced to that treatment, Trelstar, there's Prolia, there's all kinds of treatments. The first one, just the first treatment, get the lowest dose possible. Because you're giving your body a chance to adjust. The body needs to adjust to it. If you hit them, it's like the difference between a cannon and, a 22. Yeah. So opt for the first treatment of a new treatment. Always think about a lower dose. Always consider a lower dose. Lean towards a lower dose. Okay? Now, when you said the granddaddy, I don't know what the longest shot of Trelstar is. It's not 12 months, is it? Is it a year?
I think it supposedly is. But that was
Wow.
that was 3 years ago.
Exactly. And if your testosterone was already low and they hit you with a 1-year shot, they could have sent you into something where it's difficult or impossible to recover. Okay, so let me ask you a few questions that'll help me give you some direction.
Okay.
What was your Gleason score?
First reading was a 3+4. Johns Hopkins moving it to a 4+4. So in addition to the normal proton, which they would have happily done with a 7, I had to accept, I think it was 12 treatments of IMRT along with the proton.
They probably did that to the surrounding area, lymph nodes, and prostate bed. Okay? Do you know why they did that?
I'm sorry, I didn't get your question.
Did they explain to you why they used that IMRT for the surrounding area?
They said because I moved up to an 8. That was a little more.
Yeah. So it increased your risk of having some cancer outside the prostate, even though they might not even find it on imaging. It just increases the risk based on research that we have.
Prior to going up to Jacksonville for the proton, I did have a 3T MRI with a sodium
Yes.
chloride marker, and he said he could see nothing outside of the prostate capsule. No cancer anyplace else in the body.
Okay, so let's go to the 3T MRI. That's good. But a sodium fluoride is a PET scan for a bone scan. So those are 2 different types of imaging.
Well, I'm pretty sure that's what they used at the 3T.
Yeah. So they might be they don't use sodium fluoride with the 3T MRI, with the prostate MRI, or multiparametric MRI. That's a specific F18 sodium fluoride PET scan, which is a step up from a regular bone scan, which is a technetium 99. So there's a lot of new terms in prostate cancer. You might have just got them mixed up a little, I don't know. My guess is with a Gleason 8, they ran a sodium fluoride PET scan, bone scan, to just rule out any cancer outside the prostate. But I would make sure you have your dictated written report from your MRI, and just make sure you have a basic understanding of what it says. They should have given you a PIRAD score on your MRI. I would make sure that I knew what that was. PIRAD, sorry about that, on your MRI report. So I'm assuming that since radiation, your PSA has stayed low.
0.58 right now.
That's very good. I'm also assuming that your PSA might not have been really high going into radiation.
I went from 4.8 to a 14.7 in 4 months.
Oh, it was high. Okay, got it. All right. So the PSA of 0.58 is really favorable. The thing is, with your testosterone still suppressed, it's hard to tell if it was just radiation alone. You can't measure that because it's also testosterone suppression. Whether or not you can have testosterone supplementation, boy, that's really hard. There's actually a guy by the name of Morgenthaler. I think he's up in Boston. I don't know if you ever to Boston.
Abraham Morgenthaler. He says.
Did you ever consider?
Yeah, he says the whole idea that you can't have testosterone is total bullcrap.
Well, not quite.
Well, again, every patient's different, right? So what we care about is you individually, your individual situation. So how does, number one, low testosterone before diagnosis play in? Number two, how does your age play in? Number three, your overall health. Number four, your Gleason score. You can certainly measure with PSA, right? And also with MRI. So because you have had an MRI, any subsequent MRI you have, you'll be able to compare to previous. It's gonna be a little bit hard after radiation. Sorry, I forgot about that. It changes the tissue a little bit, but a good MRI radiologist might be able to help you out. So have you ever considered going to see Morgenthaler?
No. I'm living under the bubble that it's cured. I don't know what follow-up I ought to be doing. I know I have, except for the testosterone depletion to 0, that's the only side effect I can tell you I had for my cancer treatment, was just the
What?
Telstar.
Yeah, that's what we're talking about. So with your PSA at 0.58, and is it rising or is it stable?
It's pretty stable.
Okay.
It's staying right
Your
around
PSA
there.
at 0.58 after being a 14 point something, that sounds really favorable. I mean, it's hard to make a case for anything, any follow-up right now. Your question is more not about your cancer treatment, but about your side effects from cancer treatment. That's your main question.
Right.
So that is a specific kind of doctor, and it's hard, honestly, it's hard to find, but I might consider Morgenthaler. Or there's another doctor, I think, in Port Charlotte, Ed Badnell is his name. David, do you know who this is? There's a urologist in Port Charlotte who will hook him up with Ed Badnell. Ed Badnell might be able to give him his name, because he'll have a conversation with you, and he's familiar with Morgenthaler. But one of the things I would do in this situation, if it was my husband and he wanted testosterone replacement, I would make my question, I would be upset, so I tend to make my question bigger and bigger, and I would sort of argue with the doctor. I learned to make my question smaller and smaller until the doctor couldn't say no. Here's an example. Instead of saying, but I want to do testosterone replacement because nobody told me about this would happen, I would change the question to something like this. Number one, use the term shared decision making, okay? Tell them you want to do shared decision making. That's actually a very specific term in the medical field right now, and all urologists are supposed to be sharing the decisions with their patients. So start with that. In other words, I'm sharing the decision, I want to be part of the decision. Number two, what is the lowest amount of testosterone you can give me? And let's measure both my testosterone level and my PSA for the shortest amount of time, and then revisit the idea. What's the shortest amount of time you'll do that? Will you do it for 1 month, and can we revisit the whole idea? I want to take one step. I want to try. Can we do that? Because this is really important to me. Make it smaller and smaller until you get him to consider, let's say, 1 month of treatment, and then revisit the PSA, your testosterone level, and how you're feeling overall, and go from there.
Okay.
So, Ed Badnell is the support group leader in Port Charlotte, and he's got a urologist who comes to his meetings.
I think it's
And-
Dr. Meltzer, if I'm not mistaken.
Burger.
It's not Meltzer, but it might start with an M, but it's not Mark Meltzer. Mark Meltzer does cryo, it's his thing. But there's another doctor. I know what you're saying, but
Yeah.
it's not Mercer, is it?
Bruce Metzger?
Yes,
It is
I think that's it.
Metzger? Yeah, I've got his name somewhere.
Yeah, but ask Ed, Ed will know.
Yeah.
So there's, because you're wanting another opinion, you're wanting to consult with another doctor, and you will find different opinions from different doctors. So there's an idea. You can consider that, or go to Morgenthaler in Boston and look for a second opinion. And make your question small enough that they consider, and go in, by the way, with a fresh PSA test and a fresh testosterone level. So that you don't have to walk out of there and, go in with the results that you need to make your case and have your conversation.
Yeah, Laura Proton wants to tested every 3 months.
Good,
PSA and
Then-
testosterone every 3 months. Oh, really?
perfect. Then make your appointment with this doctor in Port Charlotte after you get new, fresh results from, that, Jacksonville has ordered for you. Just walk in with them. You always get your own results, right? They give them to you?
Yes.
Good. Good. So those would be my thoughts.
Thank you. very
And,
much.
I'm not an expert at the subject specifically, but I'm pretty darn good at working the medical system, which to me was what everything boiled down to most of the time, so.
That's half the battle at least. Right.
It is, it really is. So,
Anybody else? We're getting close to wrap-up time. Yes, yeah.
I start 39 sessions of radiation tomorrow, and
Okay.
I'm just trying to figure out what diet is gonna be better. I've got two different ways, low fiber, and then one is saying just pretty much that prostate cancer, fruits and vegetables, and, stay away from red meat and stuff like that. So do I need to make an adjustment while I'm under this daily radiation or not?
so a couple of things. Number one, a prostate healthy diet is a heart healthy diet.
Right.
Vice versa. So if you're trying to decide on your diet overall, just think heart healthy. Less red meat, less fat, less carbs, less salt, more fresh, more chicken, more fish, okay? So it's a little bit general, but it's such an easy way to measure. Heart healthy equals prostate healthy. Second, one of the best things you can do during radiation, believe it or not, is get some exercise in. And that's really good for prostate cancer overall. Third, one of the things you might deal with radiation is urinary symptoms. So I would ask you this, do you know your prostate size? And do you know your urinary symptom score?
This is a recurrent situation.
Got it. So this is,
I had a surgery 8 years ago.
got it. So you're doing what we call salvage radiation after
Correct.
surgery, okay. Did they do any imaging to see if they could find the cancer before they decided on radiation?
I had a gallium-68 scan at UCLA. And it
Nice,
found one
okay,
weak signal right at the, right between the rectum and the bladder. And so then I've had the fluorine 19 scan, nothing. Of course, my PSA was undetectable at that point, but I have been on ADT since October.
okay. So this PET scan is only available in clinical trials, but it's very interesting and it's one of the best tools we have. So gallium-68, I'm assuming it's PSMA also, correct?
Correct.
Okay. So you have a very specific target that they can hit.
Well, it would seem so, but it didn't show up in the CAT scan when they did that combo PET scan and CAT scan. And then the imaging I've had done here hasn't been able to find it again. It might have been an error on my part because I tend to be directive with my physicians. And so after the gallium scan, I really wanted to go on vacation for 2 months. My medical oncologist should have said, well, let's do some more imaging to get a better idea of this spot. But instead, I went on my vacation, I came back, I got on ADT, and so by the time I came down here, my PSA was undetectable.
So to try to do imaging after your PSA become undetectable means the cancer might be smaller, suppressed, even invisible and hard to find.
Right.
But I would argue that gallium-68 PSMA PET scan is a pretty good thing to go by.
I think they're gonna hit that a little extra, is what they're gonna do.
Did you also mention a CT scan, a CAT scan?
Yes.
So just so you know, the CAT scan just doesn't see cancer, it sees anatomy. So, but a gallium-68 is much more accurate at finding cancer cells, much more. I don't know the numbers, but it's pretty significant.
I was at a PSA of 0.221 when I went for my scan.
Wow.
So they have like a 50% chance of finding it at that level.
So why did they put you on ADT, which is hormone therapy like Trelstar or Lupron,
I put
when
me
your
on-
PSA was that low? What, do you have a high Gleason score?
No, low Gleason score, they put me on Zytiga and Firmagon.
What was your Gleason score?
Gleason score was 3 to 4.
3 plus 4, okay.
3 plus 4, 10% herbiform glands.
Okay. So, yeah, so overall diet, I would still argue that, we know that exercise in general, we've been discovering for several years now that vigorous exercise is just beneficial for prostate cancer. And we've known for a while that heart healthy diet equals prostate healthy diet. So maybe put some control back in your, give some control back to you for things you can do. Also, the radiation will cause some fatigue later on, so the exercise will help with that too. So,
Okay. Thank you.
does that help a little bit?
Yes, it does. I think I'm doing a little bit of an aggressive approach, but I wanted to do aggressive approach.
As long as you know what you're choosing and somebody explained your risks and benefits, fairly to you, then you're ready to make that decision. My frustration is when I give somebody treatment, they don't explain the side effects very well, so.
Are we close to a close, would you say? One more question.
Okay, one more.
Okay, I went through a radical 15 years ago. Did some radiation. It was extracapsular by the time they removed the prostate. It slowly migrated to my lumbar spine and is gradually moving up. I've gone from bicalutamide to Zytiga to Taxotere, which I'm on now every 3 weeks.
Okay.
Recently, I added THC CBD tincture to my pharmacopoeia.
Okay.
And my PSA dropped from 170 to 30. Do you have any thoughts on that?
Wow. I honestly don't, but make sure that you're correlating. So you use CBD oil,
Yeah.
which is a form of cannabis. So,
It's
which is
one-to-one.
derived from marijuana. There's different formulations. So a lot of medicine is common sense correlation. There's definitely things that we don't know. We always have to say that. We don't know that much about CBD oil, right? So if you started, make sure you're correlating clearly. So in other words, if you started, what was the date you started CBD oil? What was your PSA on that date? And did you change anything else? Did you start a different new treatment? Did you start the Taxotere then? Have you had Taxotere while on CBD oil? So make sure you're measuring clearly. And the other thing is look for any side effects from CBD oil. I'm going to argue that we don't have a lot of data, so we don't know, but we were always correlating in my husband's medical records what was going on, and then setting him up to make the decisions that he wanted. So,
CBD oil itself is legal, has been is legal.
yeah.
It's in everything from dog's food to whatever. This has THC
Go ahead.
added to it, and it's. I mean, I don't know what else to say. It could have caused 150 drop in the PSA.
Right. I think that's super interesting. I would just double check my results. Be just very sort of objective for yourself. Make sure you didn't start any other treatments then. If you didn't, then until proven otherwise, it sounds like you might have had a CBD oil response. That's your question. I would be taking my PSA more often so that I can measure that for myself. You know, that's what I would do. I would want to know if I'm seeing what I'm seeing, or am I going crazy? Because that sounds like a really good response. But the question is, were you doing other treatments at the same time? Because then you can't separate what you're responding to. So that's the main question.
Okay. Thank you.
Great. Well, thank you, guys. Jan, thank you so much.
Jan.
Welcome. So I want you to know that you're going to get a lot of this at that conference. I hope you guys can come down. It's only about an hour drive and it's free. And I'm telling you, we're gonna help everybody. We had a great, 75% of the people who reviewed our conference gave us 5 out of 5, were helpful. So I hope you can come. Our intention is to help you.
Talking about the
So-
conference they just did in Virginia, and it was very
Yes.
successful. And the speakers on this conference in March are just incredible, really. Yes?
Any chance of telecasting the conference? I'm gonna be out of state.
Oh, I don't know. Are you gonna do any teleconferencing of the conference itself?
We're a small organization, we're really not set up to teleconference, but since it's Abbey University, I am gonna try to get some, student volunteers to do either some Facebook Live or some simple recording and try to get some things recorded. So, but all of that's tentative, I can't make any promises.
No problem.
So,
That's great. Well, thank you
so-
again. It was great. Great having you
You're
as
welcome.
always.
Thank you, David.
We'll talk soon.
Thank you very much.
Okay.
Thank you.
Bye, everybody.
Well, thank you, everybody. It was great. I think it's a font of information for sure. And if she doesn't have it, she knows where to get it. Anything else that anybody wants to bring up? We're here again in a month. Dr. John Sylvester, a couple of questions that were asked today relate to what he does best, which is prostate treatment now, but radiation, thanks. Radiation treatment, and he is as good an expert on that as there is. So, and he also talks about recurrence and various other things. So we look forward to seeing him in January. Hopefully you can come. Have a Merry Christmas, Happy New Year. We'll catch you all soon. Thanks again.
Well, I necessity, yes. Yeah, I cook myself.
Thank you. It's good to see you.
I don't like to spend a whole lot of time, but I buy, I buy fresh food, I go to the store almost every day. Yes.
Excuse me, sir, one moment.
Hey, thank